This episode is based on postural orthostatic tachycardia syndrome, a vestibular physician's deep review of diagnosis, pathophysiology, and management, published by Australian Dizziness Clinics.
All right, let's dive right in. Today, we are undertaking a highly precise, evidence-based deep dive into the management of a condition that is notoriously challenging in the clinic. If you're a vestibular physician, a neuro-otologist, or an advanced practitioner, you already know that tackling complex systemic and multisensory balance disorders requires a rigorous, structured approach. It's like a giant puzzle. So we're setting that exact tone right from the start. We're going to break down the therapeutic ladder for postural orthostatic tachycardia syndrome and translate those complex clinical guidelines into a highly actionable visual framework.
So here is our roadmap for climbing the stepped care ladder today. First, the stepped care foundation. Then, graded exercise reconditioning. After that, subtype-directed pharmacotherapy. And finally, reassessment and escalation. You know, as clinicians, it's kind of hardwired into us to just reach for the prescription pad when we see an exaggerated heart rate. But we really need to completely dismantle the myth that this tachycardia simply needs a rate-lowering drug. Because honestly, the most powerful prescription in POTS is literally not a drug at all. The true first lines of defense are salt, fluid, compression, and a carefully paced return to exercise. Everything else is just an add-on. Okay, step 1, the stepped care foundation. Physics over pharmacology. All right, these are our non-negotiable foundation measures. And listen, we need to be really aggressive with these volume expansion techniques. We're targeting 2 to 3 liters of fluid daily, paired with a massive 10 to 12 grams of dietary sodium supplementation. And why is that? Well, because many of these patients have a significantly reduced circulating blood volume. We also need waist-high graduated compression garments, and we're talking a strict 30 to 40 millimeters of mercury. Knee highs simply won't cut it for splanketing pooling. Throw in a 10 to 15 centimeter head-up bed tilt to activate the renin-angiotensin-aldosterone system while they sleep, and boom, you're promoting that vital sodium retention. This visual perfectly captures exactly why those physical measures are so essential. Take a look at the gravitational redistribution of blood volume over on the left. That venous pooling drops the preload, which is exactly what drives the compensatory tachycardia. But on the right, you see the physiological mechanics in action. Compression and skeletal muscle movement directly augment the venous return. We're essentially using physics, external mechanics, to force that blood back to the heart, mitigating the very environment that allows POTS to thrive. Moving on to step 2, graded exercise reconditioning and the CHOPS POTS protocol. Now, this protocol is actually the only intervention with level 1B RCT evidence of benefit. The timeline here is crucial. We rely heavily on the phased Levine CHOP POTS protocol. Look, for severely deconditioned patients, starting them upright is just a recipe for failure. So the key is that weeks 1 through 4 focus entirely on recumbent or aquatic work. Think recumbent bikes or rowing machines. This severely limits that orthostatic load while we start building up cardiac stroke volume. By weeks 5 through 12, we can slowly introduce upright aerobic activity. Finally, at the 3 to 6 month mark and beyond, resistance training is added to really build up that vital lower limb and core skeletal muscle pump. Okay, pause for a second, because here is a massive clinical pearl for managing expectations. You absolutely must warn your patients that they are going to feel a symptomatic worsening during the first 2 to 4 weeks of this training. It's totally normal. It's an acute response to physical stress, not a sign that their disease is progressing. Honestly, sticking it out through this highly uncomfortable window is the strongest predictor of long-term benefit. All right, step 3, targeted pharmacotherapy, subtype-directed add-ons. So here is your master algorithm for escalation. A good rule of thumb? We generally only initiate these pharmacological add-ons when our dedicated lifestyle and exercise measures fall short after 2 to 3 months of consistent adherence. Notice how highly structured this pathway is. We start way up at the top in the green zones, our lifestyle and exercise foundation. Only when those fail do we step down into the colored pharmacological zones, and those choices are entirely dependent on the patient's specific pathophysiological subtype. Let's break those down. Medication in POTS is definitely not a one-size-fits-all situation. It's highly targeted. So for the hypovolemic subtype, our primary agent is fludrocortisone, working through volume expansion. For the neuropathic subtype, characterized by poor vascular tone, we use midodrine or pyridostigmine for venous vasoconstriction. If they're hyperadrenergic, we want heart rate reduction via low-dose propranolol or ivabradine. And for a select group of autoimmune cases, we might actually look toward immunotherapy like IVIG for mast cell and immune modulation. Of course, these drugs require really careful clinical oversight.
let's compare our two main agents for volume and construction. Fludrocortisone acts as a synthetic mineral corticoid, so you absolutely must monitor blood pressure, keep an eye out for potassium depletion, and check for edema. Midodrine, our alpha-1 agonist, is fantastic for daytime peripheral vasoconstriction, but here's the catch. You must completely avoid it within 4 to 5 hours of bedtime due to the severe risk of supine hypertension. I also really want to highlight this vital, highly counterintuitive clinical pearl. If you have a patient with hyperadrenergic POTS, giving them standard doses of non-selective beta blockers can actually cause a paradoxical worsening of their condition. Literally the opposite of what you want. Why? Because blocking the beta-2 vasodilatory receptors can suddenly unmask alpha-mediated vasoconstriction. That is exactly why we prefer low-dose or highly selective agents like ivabradine for this specific group.
Which brings us to step 4, reassessment and escalation, the clinical loop.
Think of this as a rigorous clinical loop. Step 1, initiate that targeted subtype therapy. Step 2, bring them back in to reassess every 4 to 8 weeks. We're closely monitoring symptom response, heart rate, blood pressure, and their quality of life. Step 3, if there's no meaningful response after several months on the pharmacological tier, we must escalate. Those complex non-responders, they're going to require a full multidisciplinary team, bringing in cardiology, clinical immunology, and psychological support for cognitive behavioral therapy and pacing strategies.
But hey, here is some great news to leave you with. International registries show that 60 to 80% of patients achieve truly meaningful functional improvement over 12 to 24 months with this combined structured approach. In video 6, we close with the differential diagnosis, prognosis, and the special populations that change management. So before we wrap, ask yourself, how many of your complex dizziness patients might actually be hiding a POTS diagnosis just waiting for this exact stepped care approach? This has been an Australian Dizziness Clinic's Vestibular Physician Review. Visit australiandizzinessclinics.com for the full literature review and clinical cheat sheet.